So we're going to talk about what is myasthenic crisis, how to avoid crisis and exacerbation, and then what to do if there is significant myasthenic crisis or significant exacerbation. So what do we mean by crisis? Well, crisis is a serious, life-threatening, rapid worsening of myasthenia and potential airway compromise from ventilatory or bulbar dysfunction, meaning weakness of chewing, swallowing, and muscles around the face and mouth. It means worsening of myasthenic weakness requiring intubation or non-invasive ventilation, such as BiPAP, to avoid intubation. A feeding tube without intubation is considered severe MG, but not considered crisis. And the reason why I think it's important to define it is in that many medical professionals will use crisis and exacerbation somewhat interchangeably, but crisis is actually a very defined entity, including airway compromise and respiratory involvement. Impending crisis is rapid clinical worsening of myasthenia that, in the opinion of the treating physician, could lead to crisis in the short term, meaning days to weeks. And exacerbation is everything else. So if there is significant worsening of limb weakness, weakness of the arms or legs, or swallowing, but it doesn't meet criteria for crisis, that is considered exacerbation. And these are definitions that are drawn from the international consensus guidelines that were recently published. So how common is crisis? Well, it's actually relatively uncommon. Because of the difficulties with terminology, epidemiologic data are somewhat difficult to ascertain and somewhat limited, but we think that the lifetime risk of crisis in myasthenia is about 10 to 20%. So it's uncommon, but not rare, and certainly it is a major concern in myasthenia. We think that the annual risk is about 2 to 3% per year. In Lambert-Eaton myasthenic syndrome, crisis is very rare. And so respiratory dysfunction in LEMS that progresses to full crisis is so rare that there are only case reports in the literature. And in my practice, I've seen this only once. I mean, it's very, very, very rare. When and how does it happen? Well, crisis in myasthenia gravis usually happens in the first couple of years of myasthenia when disease is most active, and sometimes at the disease onset. Symptoms leading to crisis are generally progressive over hours, days, and weeks, and leading to the event. Generally, it's not sudden. So although it might feel like it is a sudden deterioration, usually in hindsight, there is an escalation of symptoms over time. How is crisis treated? It is treated with IVIG or plasma exchange. We also initiate or adjust baseline immunosuppressive therapy at the time of crisis. And what is the prognosis of crisis? Well, the vast, vast majority of people recover very well from crisis, though it does not happen overnight. The in-hospital mortality from myasthenic crisis is low, approximately 5%, though intubation with myasthenic crisis can be prolonged and averages between 10 and 14 days. So what causes crisis or exacerbation? Well, triggers of crisis or exacerbation are different for everyone and can change over time. And many times there's a snowball effect of several triggers or no trigger is identified. What are some common triggers of exacerbation? Well, medication changes, so reducing medications for myasthenia, such as reducing prednisone over time or a prednisone taper. starting other medications which can worsen myasthenia, such as fluoroquinolone, antibiotics, or other medications on the list of meds that can worsen myasthenia. We know that stress can contribute to symptoms and worsening, infections, fatigue or overdoing it, temperature and mainly heat, and surgery, including thymectomy. What about medications worsening myasthenia? Well, we know that some medications may worsen weakness in myasthenia in some people. The list is readily available in many different areas. So there is a complete list on the MGFA website. There's a list on the MyMG app. And we also print out a list in our clinic, and many clinics do the same. And we encourage patients to take a photo of the list on their iPhone if they have a smartphone, or keep a copy in their wallet to also have readily accessible when you're seeking care with other physicians who might not be familiar with the list. We encourage you to discuss the list when you're being prescribed a new medication, and notify your neurologist of any changes in your other medications. And so what about stressors that can contribute to exacerbation of myasthenia? Judy and I were talking about certain stressors, and we thought about the stressors that people generally report and how that might be different in myasthenia or unique. And stress is common. I mean, life is stressful, but there's also in the setting of disease, we all know that responsibilities for family, children, and parents, job change or realizing you may need to change your jobs or adapt can be stressful. Financial stresses, treatments for myasthenia can be costly, death in the family or of somebody close, and just general stressors can, over time, lead to worsening of myasthenia. Surgery can trigger exacerbation, and so what we try to do is communicate with the surgeon ahead of time and encourage communication between the surgeon and the neurologist. We share plans, we decide whether any pre-treatment with IVIG or plasmapheresis is needed, or any adjustment in the baseline immunosuppressive therapy is needed to try to prevent worsening associated with the surgery. And we discuss plans for anesthesia, and we make sure that not only the surgeon but the anesthesiologist is aware of the diagnosis of myasthenia. And sometimes if it's a complicated surgery or if there are questions regarding anesthesia, we encourage you to meet with the anesthesiologist ahead of time to discuss a plan for anesthesia far in advance of the actual morning of the surgery. What about heat and humidity? Heat can can worsen symptoms of myasthenia. So we recommend avoiding hot showers or tubs or baths or hot tubs, using air conditioning or fans in warm climates, particularly if you know that you're susceptible to the effects of heat in terms of your myasthenia. And so what are some more do's and don'ts to avoid exacerbation and crisis? And for this, I'm going to turn the discussion over to Judy.
Don't wait for your medication to run out. Don't wait till Friday towards the end of the day to call and say, I need a refill. Don't wait for your pharmacy to say, I've sent 3 faxes to Judy, she hasn't filled it. Give me a call. I would rather have you call me than run out of your medication. Don't change your medication without letting me know. I know a lot of you, after you get used to your, you'll take another Medecine here, or you'll take another prednisone here. Well, if you do that, let us know so that we can have it documented. And then if something else happens, we can have it documented for the ER so they know, if something goes on. Call us if you are having any worsening symptoms. If you have a death in the family, a spouse dies, someone else, so that we can, make people aware that, you may or may not go into a crisis situation with this, but if you do, let us know so that we can kind of hopefully help ward it off. Communication is the big deal. I mean, I stress that big time. Call, know your nurses, have your family members know your nurses or your physicians and able to get in touch with us so that, we can help avoid any type of crisis or exacerbation going on. And listen to your body. And also have your family members. Some of you may be aware, think, oh, well, it's not that big a deal, but your spouse is like, well, they are altering what they're eating. They've been eating cottage cheese all week. When I say, can you swallow, you are, and your family member says, no, they've had, pudding all week. Well, okay, your swallowing is being affected. You're just altering what you eat. So just listen to yourself. And everybody's different. Don't compare yourself to one to another. I don't have one patient that's the same. And I've been doing this for 8 years. I don't have any of my people that are the same. So communication is the big, key to avoiding crisis.
So what about fear of crisis? So there's not really been a formal study of this in the literature. I think it would be very interesting to do, but experience shows that many people really, I hear this in my office, people are afraid of crisis. It's the first thing on everybody's mind at the time of diagnosis. People are afraid of recurrent crisis if you've had crisis, and it's something that really is pervasive. And so part of my job and part of our jobs as medical providers in different venues is to help work through that fear of crisis, and put the risk into perspective. So when people are diagnosed, a common fear is, myasthenia equals crisis, and everyone is going to go into crisis. But the numbers show that that is really not true, that it's the minority of patients who go into crisis. And so by understanding the actual numbers, the actual risk, that can be very reassuring to many, many patients. And so as providers, we generally ask about fear of crisis as a first step to open the conversation. But definitely, bring this up with your healthcare providers if this is something that's on your mind and that you're worried about in any time in your disease, to realistically discuss what your current risk of crisis is. So all of these things that we've talked about are designed to try to prevent crisis and to prevent exacerbation. But sometimes there is impending crisis or crisis. So when do we recommend going to the emergency department? Well, if you have trouble breathing, if there's significant trouble swallowing foods, liquids, or saliva, if there's severe slurred speech, because that indicates severe bulbar weakness or weakness of the muscles around the mouth and the swallowing, which can progress to difficulty with breathing or managing secretions, or any severe or rapidly progressive weakness, especially involving the neck. We know that neck weakness often correlates with weakness of the diaphragm and muscles that control respiration. And so if you're having difficulty holding up your head, finding that you're needing to put your hand underneath your chin to support your head, or having difficulty tucking your chin to sit up, those are all warning signs that weakness could be involving respiratory muscles. And when is the weakness severe enough that you should call 911? If you're having trouble breathing, if you're unable to swallow saliva, and if you have any of the symptoms that are indicative of impending crisis and you cannot be transported to the ED otherwise. And so what do we recommend that you carry with you? So we recommend that you have an emergency alert card. And this is available on the myasthenia.org website, and it's really handy. So it says, it has information about the diagnosis of myasthenia, and it has information about other medical conditions. I know this is very small, and current medications that you're taking, and there's a list of drugs to avoid or use with caution, and then some general tips for management for first responders of severe respiratory problems or severe swallowing difficulties. And all of this folds up nicely into a pocket-size card. Generally, we recommend having an emergency contact as well, someone preferably who's close to you, who's aware of the disease process, who can be an advocate for you. And consider a medical alert bracelet. This is a very personal choice. Some people are interested in wearing one. Some people are not interested in wearing one. We think it might be most helpful if if your myasthenia includes severe speech or a history of crisis. Some of the medical alert bracelets really look like other types of bracelets these days, and so aren't necessarily known as a medical alert bracelet, and that can be helpful or give some comfort to some people. So where to go? So many people receive care for their myasthenia very far from home. So just out of curiosity, how many people travel over 2 hours to get care for their myasthenia, just by a show of hands? How many people travel over 1 hour? Okay. How many people travel to another state? Okay. So that's pretty amazing. And so this is a map of my local area, and it's hard to see here, but Boston is somewhere down here, and we have patients who come from all the way up in northern Maine or out on the Cape and the islands, and patients come from 3 or 4 hours away, just like you. And so if they're having crisis, it's not really practical to recommend, to come to our emergency room to be seen. But we know that people are feeling that in their local emergency room, the doctors might not be as aware of myasthenia as they would be if they came to, a major medical center. So how do we reconcile that? Well, we say if the shortness of breath or severe trouble if there's severe trouble swallowing, the closest emergency department is best. The hospital will consider transfer if it's appropriate. If symptoms are moderate and if there's not significant shortness of breath, if the symptoms have been gradually escalating, one could consider traveling to the hospital where you get care for your myasthenia. Of course, we recommend making this decision in concert with your neurologist who's taking care of your myasthenia. We know that ambulances will often transport to local emergency departments and can't always transport to the center where the myasthenia expertise is. So what happens in the ambulance? First responder care is focused on the ABCs, so airway, breathing, and circulation. It's focused on keeping an open airway and supporting breathing, and that will be the goals of emergency care. You can, if you're having trouble breathing or having difficulty swallowing, you can ask, if possible, to put the stretcher in an upright position to help with breathing and swallowing. You can ask to have suction available to manage excess saliva. The ambulance can be kept cool to avoid overheating, which can worsen weakness in myasthenia. And I'll ask Dr. Allin whether, as a director in the emergency department, any thoughts about pre-hospital care in myasthenia?
I'm both an EMS medical director, and I have been for the last 30 years in this for this city, along with chair in emergency medicine. So I kind of look at this from both ways. And I thought you put a very nice spin on what you might run into in a small community hospital. The fact of the matter is, you're more, if you're in a small community hospital, it's a good chance the doc seeing you doesn't know jack about your disease. That they need to. It's just the way it is. I mean, you may be the. I saw an MG patient once, and as you guys know, if you've seen one myasthenic, you've seen one myasthenic. I mean, if you've seen 10, they were all different. And I'm also the victim of a chronic, lifelong disease. I'm a diabetic. I have been for 40 years, and there's only one person that knows my disease better than I do, and that's my endocrinologist. I know my doses. I wouldn't let anybody besides my endocrinologist and, to my wife's chagrin, myself, change my insulin dosages. She doesn't think I'm the expert that I think I am at my diabetes. The first thing you do is advocate for your disease. Tell them what you got. Tell them how you feel. Tell them the last time, when I feel this way, this is what happens. Because you might come in and say, I'm a little bit short of breath. What do they hang on you? Pulse ox. Wrong test. It's not going to tell them anything. I can tell if you're hypoxemic walking in a room. What I want to know is, how is your respiratory function, your negative inspiratory flow, your functional capacity. How are those doing? And if I want to do it simple, I'll say, hey, take a deep breath and start counting for me. And if you stop at 10, because you got to take another breath, that's a problem. And it's no fair to count in your head. I want to hear you breathe. No head counting. If you can't count to 50, just tell me. I'll help you. We'll go in series of 10s. I'm also one of the sideline physicians for the Chiefs here. And when people start talking about counting backwards by 7 from 100, I'm like, well, half these guys can't do this on the best day of their life. So name the months backwards. Okay. Can you write them down for me? So advocate for your disease. If they want to give you a med, don't let anybody hand you a pill. I say this to all my patients, because I tell you what, the one thing I figured out in doing emergency medicine for over 3 decades is, every patient I see, I just realize how much I don't know. And you've got to speak up. Don't let anybody hand you a pill and take it to you and say, what is that pill? What does that do? If you don't recognize the name, say, what family is that? Oh, that's a fluoroquinolone. Why don't we skip that? Why don't we go to something else? You didn't recognize the name? Oh, this is Avalox. You'll do great. What the heck's Avalox? A fluoroquinolone. So, ask them what it is. I love patients that do that to me, that just challenge, what's that drug? What are you shooting in me now? Because it may be something that really doesn't serve your purpose. The other thing that we get very territorial about, and I don't understand it, because I'm never too proud to get help, is calling your doctor. Have you called her yet? I want to wait for 3 hours of tests to come back. Could we please not do that? Could we just talk to them now? They may have some really good ideas, because it's not as simple. It might be a urinary tract infection, right? It might not even be a crisis. But I pretty much ought to talk to your doc about, are you immunocompromised? What's my best antibiotic? What's my antibiotics to avoid? I'm telling you, ER docs don't know all that stuff. They've got to talk to the specialist. If you're short of breath, heck, it could be pneumonia. I got to figure out what antibiotic to use. It could be, sometimes this gets accompanied by other inflammatory diseases. You could have myocarditis and be in heart failure, which will be echoing you and seeing what your ejection fraction is doing. I mean, there's a lot can happen. That's not just that's not just an MG crisis. If you come in a pneumonia and you're wheezing, and somebody walks in with a syringe of juice to shoot into you, well, that's one of two things. It's either an antibiotic, and your question is, what antibiotic is that? Or it's steroids because you're wheezing. Well, you need to know somebody's about to shoot 125 milligrams of Solumedrol in you after you've just weaned off of your steroids. I mean, there's just things to think about that sometimes we don't. We go by rote. We live by pattern recognition. You got this, I do this. You got this, I do this. You got something that breaks the pattern, I've got to slow down. And this disease certainly breaks the pattern. A little bit something about EMS. If you're in an accident, if you're a trauma patient, do not let them, this day is over. Do not let them strap you down flat on your back on this backboard that's like a bed of nails. Says the backboard's done. It's done. It's an extrication tool. If they've got you strapped down a backboard, it says, here's what we're going to do next, Mr. or Miss Paramedic. Here's what we're going to do next. You're going to take that backboard out and you're going to let me sit up. Because it's completely safe. It's completely safe. If they want to leave you strapped down, they're practicing medicine from 10 years ago. They may want to leave a collar on you, which will bug the heck out of you. And there's about this much more evidence for the collar than there is for the backboard. Because what happens if you break your neck? What happens your spinal cord injury? You got it right there. You're not fine, and once you turn your head, now you're paralyzed. You got what you were going to get at the time of the accident. So does it help much to wear that collar? If they've got this collar, because EMS, anybody ever had a collar in EMS, you know, it's one size fits no one. It's either up under your nose, or it's down here digging into your hyoid bone. One thing it's not going to do is fit. And so you can't swallow, you can't breathe. I mean, it's tough. And I'll tell you what, it ain't worth that. Sit me up and just take me to the hospital, please. But no backboards. If you're having shortness of breath, sit up. We even intubate now with patients sitting up. Why do we do that? Do we do it because it's easier on us? We do not. Doctors don't do anything because it's easier for us. We're not supposed to. It's supposed to be easier for you. What does that do when I sit you up and I'm going to intubate you? It buys me time before you get hypoxic. And I don't care who you are. And I don't care what your disease is. It buys me time. Most ambulances now will have CPAP. If you're having trouble breathing, they can put you on a continuous positive airway machine. And what that does is it decreases the work of breathing, which is exactly what the problem is. You can't do in a crisis many times the work of breathing. So ask them about it. Hey, you guys have that CPAP thing? If you're in any size EMS system, they'll have it. And most EMS systems are designed to take you where you ask to go. We have 3 main services in this city, and every one of them will take you to any ambulance, to any hospital in the city that you request to go. Now, at 2 in the morning, they don't feel like it, so don't let them tell you otherwise. I mean, I want to go to this place. And most big centers have transfer centers, one-call transfers. I'm sure you all do. We do. It would take one call to talk to our neurologist. and get somebody transferred. One call to one number. So almost every big center will have that. And so there's really no reason that a hospital, no matter where you end up, can't get a hold of your doc. Almost no EMS agencies, there are some, but not many, will try to intubate you in the back of an ambulance anymore. That is we found out that's not that safe. And probably we're better off if you can tolerate it with positive airway pressure and being transported before somebody tries to intubate you. And I would always try to non-invasive positive pressure, BiPAP or CPAP first. And the last thing I want to say, because it helped me personally. I love it when patients do this, when they come into the ER. I don't know your values. The only thing I can't do is project my values onto you. And if I don't know you, that's what I'll start doing. I'll start projecting my values onto you. One of the things we just really enjoy are people having DPOAs, durable powers of attorney. I was my dad's when my dad was dying, but you don't have to be dying. My wife has mine. I got hers. I guess that's what you get for 36 years of being married is she owns you. Which is great. She takes care of me better than I do myself. But if you can't speak for yourself, that person speaks for you, definitively speaks for you. And it's someone who knows your values, who knows what you want. In the state of Kansas, I don't know about Missouri, but in the state of Kansas, by state law, no family member has priority over another to say what's going to happen to you medically. So if my wife didn't have my DPOA, I've got 3 grown kids. They would just be in a tussle about what to do. That's ridiculous. My wife's the boss. She is now, she is if I can't speak for myself. And the kids have nothing to say about it. My mother couldn't come in and say, oh no, we're not going to do that. She's the boss. And I'll tell you what, that is an extremely, extremely powerful piece of legal ammunition that is available to you for somebody to speak for you. You come in, you get intubated, you can't speak for yourself now, you're sedated, you want somebody now to be your advocate that knows you and knows your disease. We have a lot of that go on now in our city DPOAs, and it really, really is very, very helpful.
So I think we've gone through all of the things that can go on in the emergency department. I would just highlight that all of the neurologists who take care of your myasthenia, we're delighted to get calls from the ED. We want them to call us. And we are available to them and day or night, and we want them to call. So when you are meeting your neurologist and setting up care, you might ask them, hey, if I end up in the ER, what is the best way to get in touch with you? How does your practice work? Just so you know what to expect before you're in the minute. But we definitely want to be called. We will talk more about how to assess respiratory function in myasthenia, but Dr. Allin emphasized that oxygen saturation is not a reliable measure of breathing function in myasthenia. Hypoxia, or low oxygen, is a late marker of respiratory distress. A single breath test is a better bedside measure. And what this involves is a long exhale followed by an inhalation, and then counting up as high as you can go at a rate of 2 per second to see how high you can count on that one breath. And generally, if you're able to count above 25, that is a good correlate of normal respiratory function and good neck strength. If myasthenic crisis or impending crisis is present, a breathing tube can be inserted or BiPAP used. If breathing or swallowing is markedly affected, you'll generally be moved to an intensive care unit, either in that hospital or via transfer. And then IVIG or plasma exchange is typically begun in the hospital. Generally, the care of other emergency medical issues like heart attack, stroke, or trauma is not significantly affected by stable myasthenia. The exceptions to that are medications to avoid, possible immunosuppressed status, and then the possible increased risk of fracture after steroid use. And so just in summary, myasthenic crisis is an emergency where severe weakness causes respiratory failure. It is rare, though we always think about it and want to try to avoid it. It occurs in less than a quarter of patients with myasthenia. Avoiding triggers is important, but sometimes no trigger is identified. And sometimes it's hard in the acute emergency to determine what symptoms are due to myasthenia and what are not. Is that shortness of breath due to myasthenia, or is it due to a pneumonia? And so a complete evaluation needs to happen. Some first responders may never have seen a patient with myasthenia, or the patient they saw is just that one patient. Goal is supportive care until full assessment can be made, and the information that you provide can be extremely helpful in emergency situations. Having that up to date and accurate is key.